Good evening. My name is Michael Potter. It is the 25th of September, 2020. It is approximately 22:35, and we will be doing our final case connection 4, dealing mostly with the urea cycle. You can see a nice pretty picture of our urea cycle, starting in the cytosol of the mitochondria and moving in a nice circle. We'll detail a little bit of this later, but for now, we're going to move on to case number 1. This is a newborn girl, appears normal at birth, but within 24 hours, she develops lethargy, hypothermia, and apnea. Her physician orders a lab of tests, a panel of labs, and he suspects a metabolic disorder. Blood glucose, urinary acid, serum fatty acid, and plasma glutamine come back, and we move on to our first question. Urea cycle disorders versus beta oxidation disorders. Whether or not either of these tests are able to differentiate or further study needs to be done on the child to differentiate between the two. So first we're going to have blood glucose. Whether it be due to decreased breakdown of fatty acids into acetyl-CoA, or whether it be increased catabolism of protein. Either way, this patient is going to present with hypoglycemia, so blood glucose is not going to be an effective determining factor whether or not this is a urea cycle disorder or a beta oxidation disorder. So, urinary acid. Acidity will increase with both these sets of disorders. Either way, either the urea cycle deficiency is going to increase acidity, or the beta oxidation of fatty acid is going to increase acidity. Either way, this patient is going to be acidotic at some level. This test alone is not going to be able to differentiate between the two sets of disorders. Serum fatty acids are our next test. We're going to end up seeing increased lipolysis in both sets of disorders, which is going to increase the serum fatty acids. Free fatty acids will be increased in both of our disorders with beta oxidation deficiencies or the urea cycle deficiencies. Obviously, this is not going to be effective in differentiating between the two sets. So now we move on to plasma glutamine. As you can see, I've got our beta oxidation here and our urea cycle here. First thing you'll notice is as our glutamine is heading to the kidneys, we're going to have increasing glutamine here, obviously. This overall urea cycle, as we have a deficiency in it, we're going to have a backup and ultimately lead to glutamines being unable to be extruded from the kidneys. And with a buildup of glutamine, we're going to have increased plasma glutamine. However, in the beta oxidation chain, we don't see any secondary byproducts or primary byproducts of this being glutamine. So with no increase in plasma glutamine, we can definitively say that it is not a urea cycle disorder. That doesn't mean it's not something else other than the beta oxidation. However, it is not a urea cycle, so we can confirm that the patient doesn't have a urea cycle without glutamine. However, with the glutamine being raised, we can strongly consider this being somewhere in the urea cycle having a deficiency. When we look at our lab values, as you can see, our everything except for the plasma citrulline is elevated, in our ammonia levels, and our urinary uric acid are increased and significantly. Obviously, if our number here is supposed to be 0 to 3 and our number down here is 473 micromole per liter, that's a significant elevation. Obviously, with the initial elevation at birth and then a rapid raise to 600, we can certainly see that the ammonia levels are critically high. So what's our most likely enzyme deficiency? As we're looking here, we know we have a excess of uric acid, but a normal citrulline. So our most likely candidate for our deficiency is going to be our ornithylene transcarbamylase, or OTC. The buildup of the downstream product here of uric acid, specifically the byproduct here, and the normal citrulline level would definitely indicate that the ornithine transcarbamylase is going to be our most likely culprit in this child. The next question being, what's our least likely enzyme deficiency? And again, we look back at we have a elevated uric acid. So obviously this has got to be created. So the carbamyl phosphate has to be being synthesized from our previous precursor. So carbamyl phosphate synthetase, or CPS1, is going to be our least likely enzymatic deficiency. We can't say it's not something further up the line. Down here, we can't say that it's not something down here in there, but we can definitely say that excess uric acid is being created, so the least likely is going to be our CPS1. So moving on from there, we move to case 3. This is a 47-year-old man, presents with a severe pain in his right great toe. He's unable to bear weight. These are very classic signs for gout. This buildup of uric acid creating crystals in our small tissues and causing joint damage. This is very typical presentation. So labs are drawn and we find his plasma urate is high. Again, another finding we would expect to see in gout. With his urinary uric acid significantly decreased. You can see right here, 413 plus or minus 78. So we are well below even the statistical deviations here. So gout. Gout is usually considered a lifestyle disease. It's generally considered due to excess, much like diabetes is considered a lifestyle disease a lot of times. But as with diabetes, we have many genetic causes of gout that make us predisposed to gout. But as you can see, crystals are formed, and uric acid crystals are formed, and end up depositing in the lower extremities a lot. This is showing the great toe. However, the knee is a very common place, almost the most likely place for these monosodium urate crystals to aggregate and start causing damage. All long-term effects, arthritis, and further down the line, some significant joint damage. So here's our potential causes of gout that we are going to look at. Overproductions of purine, decreased salvage of purine, and decreased urinary excretion of uric acid. So when we look at these findings, with our lab findings earlier, we saw that our plasma urate was elevated, and as you can see, all of them are going to have an elevated plasma urate. But our urinary uric acid output, with an overproduction of purines or a decreased salvage of purines, there's going to be increased urinary uric acid. As long as the kidneys can put it out, we're going to have excess. Now, if we have an issue with our kidneys not putting it out, let's go back here, then we're going to have a decreased urinary uric acid. Just if we can't push it out, it's going to be down in the urine. So obviously, decreased urinary excretion of uric acid is the most likely culprit in our patient with gout here. Also, it should be noticed that under excretion of the urea is responsible for 90% of these hyperuricemia cases. It's the most common. Again, we look at the kidneys just are unable to keep up with the amount of urea being created. The urea backs up. That urea ends up causing these crystals, as we discussed here, to build up, and we see a gout. So now we talk about the patient decided to switch from diet to regular soda. Diet soda, in this patient was told that it is bad for you. The fake sugars are causing issues and cancerous and all sorts of things that we've heard in the news, but he now drinks 5 liters of regular Coke a day. obviously, our standard sweetener nowadays is this fructose. It is long-lasting on the shelf, unlike regular sugar, glucose. It can certainly last much longer than natural or the glucose. So, unfortunately, a natural byproduct of our breakdown of fructose. So, with fructokinase, with ATP, we have fructose 1-phosphate, bisphosphate. However, this creates ADP. With the adenylate kinase, we have the ADP being converted to AMP. Adenosine monophosphate is what AMP is. It moves into the inosine monophosphate, IMP. We push down into the 5' nucleotides, ATP. We have inosine, so we have kind of pulled off this monophosphate and created an ATP molecule. We have some byproducts here, a few more reactions to xanthine, and more uric acid. This is not seen in diet soda because artificial sweeteners are not metabolized for the most part. Cyclamate, saccharin, and acesulfame K are not metabolized by the body in any significant amount. There's no residues or anything left, and they certainly don't break down into the urea cycle, no increase in ammonia or need for excessive urea. Aspartame is metabolized in its components, aspartame and phenylalanine. And in a strong acidic environment, we have it also methanol ends up being created. So, also in basic conditions. However, I just did want to make something note of here. Sucralose was traditionally deemed a non-metabolic sweetener. However, there is recent suggestion that there are distinct metabolic products formed post-ingestion of sucralose. This is done by testing patients pre and post administration of a decent amount of sucralose and having some distinct newly introduced metabolic processes. Nothing I could find showed that they increased urea or caused any of this these crystals to be formed. However, just a note to be had. But that is to say that the metabolism of neither aspartame or sucralose has an experimental demonstrated to raise uric acid levels, thus no increase in gout symptoms. Citations are here. They're also on my paper that I'll be submitting along with this. I do want to thank you, and this is my last chance to say I want to thank you for the class, and I certainly learned much more than I was anticipating. I know it's 7.5 weeks in, but I killed myself to get through it. And again, thank you, Dr. Ott and the rest of the team. You guys have a wonderful future endeavors. Have a good night.